The last step in this hip protocol is the internal rotation. So let's go through the assessment here now. If you've done the first two steps right, you probably start to see a big increase in their internal rotation already. So it's really important that you assess their internal rotation before you begin any of the treatments. So go through your hip extension first, find out the restrictions there, then go through your hip abduction and then your internal rotation. And then you've got a level playing field of knowing how much you're getting in terms of change to some of these areas, and especially the internal rotation is a big part of that, because that tends to let us know how much restriction there is. So there's two parts to this. We're using a passive range of movement. So what we're looking for is one, the range of movement, and the second is where they feel it. So this part is really important because it gives us the last chance to clean up any other little restrictions that may be still just floating around there. So it's really imperative that you do this and that you nail the areas that we're looking at in terms of restrictions. Now, there's a couple of areas that we'll see that will maybe sometimes be the main restrictors. The main one for us for internal rotation will be the TFL. 90% of the time, that's where I find we'll find the restrictions. However, there could be also the possibility of the adductors being part of it. Once again, iliopsoas could be, or even the deep external rotators. So all of these areas potentially could be the restrictor in this last bit of the internal rotation. Okay, so the hip's going to be in 90 degrees, okay, flexion, and obviously the knee as well and the hip, so both at 90 degrees, okay. Support the heel, okay, and also support the knee, and we're just going to bring the hip out towards you, because what we're looking at doing is internally rotating the hip, okay. As much as you see the foot coming out, it's actually the hip that's going in. So what we're looking at here is one, how much range of movement, and obviously the second part is where they feel it. Okay, so if they're feeling it in here, then we know we're probably looking at doing some work on the adductors. If it's right through the anterior portion of the hip, we know that's probably iliopsoas or rec fem. And if it's more out here on the lateral, then we're looking at TFL. And like I said, 90% of the time it'll be that TFL. Now we're looking at the treatment. Now, as I've mentioned to you beforehand, TFL is pretty well much the most common restrictor that you'll find for that internal rotation. However, there may be opportunities where you might find the anterior hip, which will be the iliopsoas, or even the adductor magnus, okay? Very, very rarely, but just now and then, you might also get the deep external rotators. So it's imperative that as you check through this range of movement, that you isolate the areas where they're restricted. Okay, I'm going to demonstrate the TFL because it's the only one that I actually probably haven't shown you beforehand. So it's quite simple. I'll draw the TFL in here for you. Obviously, we're not just looking at treating the TFL, it's the area around that TFL, okay? So obviously we're bringing in a little bit of the fascia as well. So the TFL comes along here, and obviously with Tess, she's got a big TFL, being a 400-metre runner. Now, the treatment process is about having the hip in some flexion, but the key will be having the knee going over into adduction, okay? So that's where we're challenging the range of movement. And as you can see, the TFL starts to lengthen there as we go through that range of movement. So we've got a couple of different ways to go about this. First way is obviously to use a soft fist approach, and look, that's probably the main focus for me. That's what I tend to do. You can then come in with the broad forearm as well, do the same sort of process. So it's up to you which way you'd like to do it. They're both just as effective, so I would keep in mind that you experiment with which one you want to do. There is a trigger point in the superior portion of that TFL, so sometimes you might want to focus just sitting on that as well, and I do that from time to time, especially if you're having a little bit of a stubborn TFL in terms of the releasing, okay? So it is about working through that tissue and bringing the knee over into adduction, all right? And as I said, if you do this properly, you should be only 3, maybe even 4 times to go through this process. Once you've done that, you need to take the hip back up into that internal rotation and then work through and have a look and see if there's any more restrictions anywhere else in and around the hip. And if there are, then you apply the techniques. If there are areas that are restricted and they're being stubborn, then sometimes that may be the fact that there is a structural restriction underneath. So keep in mind there can always be some structural restrictions, but for the most part you should find that the technique works really, really nicely in picking up any of those restrictions that are left over. There is the opportunity also, once you're working through this tissue, that you'll tend to get a really good idea of where the restrictions are. So the more you get familiar with this technique, the more you'll know where these restrictions are. And I actually can probably tell where they are just by testing that internal rotation myself. Okay, so this is the last part of the technique and the protocol. Primarily you're trying to clean up any of the restrictions around that hip, and what we're looking for is basically a plateauing out of any of the restrictions around the hip as we test internal rotation.